Welcome to In the ED Now, a podcast that makes you an excellent emergency department physical therapist. I'm Dr. Rebecca Griffith, the ED and I'm so excited to have Dr. Taylor Bush with me here today. And if you've been following along for a while, my original podcast, when I really had just absolutely no idea what I was doing, and Taylor was kind enough to be my second guest on that. And she spoke a little bit about what it was like to be a student in the ED and then a new grad in the ED, because I get asked that all the time.
Yeah.
And so today I'm so excited you're back and we just want to follow up and see how everything's going.
Yeah. Thanks for reaching back out. I didn't realize at the time that I was the second person you had on the podcast. And, you saying I didn't have my stuff together. Absolutely disagree. You were great.
Well, no, you were like guest number two, and I just really appreciated you like trusting me and being willing to do it and telling everybody your story. So I can't wait to hear what's happened in the interim.
Yeah. It's been, excuse me, a crazy ride. The fact that we're coming up on me being in the emergency department for almost 3 years now, excuse me, is really insane to me. It feels like no time has passed at all, but then also I feel so much more confident in how I practice as a therapist now than the person I was, I think, when we spoke 2 years ago. And so it's been an interesting journey.
I love that. So tell people a little bit about how this journey started, especially if they haven't heard that first interview. I'd encourage you to go
Yeah.
back and listen to it, but catch people up, tell them who you are and what you do.
Yeah, so my name is Taylor. I'm a staff physical therapist in the emergency department, primarily at Flagstaff Medical Center. I have the luxury of being involved in one of the first PT and the ED programs in the country. So that
Yes.
really, makes it pretty easy for me, which is great. Um, I actually started out in Tucson working for John Davidson, who was one of the people who started this whole physical therapy in the emergency department movement. And he had like a picture, he was on a magazine cover, and he had that framed by his desk. And I would always be like, what is this? What's this about? And I had no idea how big of a deal it actually was and how
Mm.
huge of a movement that he started. And then so when I went to PT school at Northern Arizona University here in Flagstaff, we had a couple of staff members and professors who had worked in the emergency department before. And so they kind of told us little tidbits. And I always thought, oh, that sounds really cool and interesting. And like nothing I knew that it existed. And then I was lucky enough to score a rotation in the emergency department here, working with Lisa Tenbarge as my CI, which is amazing.
The legend.
Yeah, the legend, exactly. And I knew that this was the setting that I wanted to work in, but this was right on the tails of COVID. And so, a lot of emergency departments were not hiring. I had reached out to a couple across the country, and they were like, oh, we're not really hiring anybody right now. Sorry. And the last week of my rotation, Lisa said to me, hey, someone's leaving and there's going to be a spot opening up. If you're willing to wait a few months, we can have you start in the emergency department. And I said, absolutely. So in June of 2021, I started working as a new grad in the emergency department 3 days a week.
I love that.
Yeah.
And what made you want to do it? Like, because being a student in ED, I think is overwhelming and scary.
Yes. Yes.
And then what made you feel like, gosh, this is what I want to do? Because this is not what you originally wanted to do, and probably not what you learned about in school.
Right. Exactly. I really wanted to be involved in sports physical therapy. I liked the high level aspect of it. And I thought that it would be a good challenge. But the more that I learned about the emergency department, I was like, that is a challenge if I've ever heard of one. Um, and I had two rotations in outpatient, which I loved, and they were great experiences. But what I enjoyed the most about my rotation in the ED was that every single day was different. It was
Hmm.
hard to be monotonous, right? And it really forced you to have good diagnostic skills and work through a problem, which during my time in PT school, I realized was an aspect that I really enjoyed about being a physical therapist. So yeah, after my 10 weeks, I knew that absolutely this is what I wanted to do. And I felt like if I was ever going to try to get into it, I had to do it as sooner than later.
Yeah, I love that. And I just like that transformation from wanting to work with professional athletes to working with anybody who walks in the door is amazing because you're talking about like going from the elite, like cream of the
Right.
crop, to like the safety net of society.
True.
And both are like admirable missions, right? But like, I'm really proud of you for the work that you
Oh,
do.
thank you.
Because physical therapy really shouldn't be a luxury, right? Like those professional
Yes,
athletes, they need physical therapy. It's not a luxury for them, it's a requirement. But for so many of our patients that are coming through the door in the emergency department, they may never encounter a physical therapist in their lives if they
right.
don't see you in the ED. Do you have like a moment you can share about that with somebody who like otherwise wouldn't have seen anybody like you?
Yeah, someone that sticks out in my mind was a gentleman who I was consulted to work with him as he had positional vertigo.
Mm,
He is unhoused here in Flagstaff. He has a problem with alcohol use and had been into our emergency department multiple times. Amongst his complaints was always that complaint of dizziness. And one of the ED physicians was like, "Let me have you see him." And he was telling me that it had been like years on and off that he was suffering with this. And
mm.
it truly was a positional vertigo. We were able to really make a difference within one session, and he was so grateful. And I do think he had no access. Like you said, we are his safety net. He had no access to anyone else who was going to be able to really treat this. And luckily, he worked with the right physician that day who thought, "Hey, I think this actually is a positional vertigo, not entirely related to alcohol use." And
Yeah.
would benefit from PT. So I've enjoyed working with people like that who, like you said, otherwise may never have access to something that can be so simple and really effective in their day to day life.
Yeah. That's for me, that's the mission, right? That's the
Yeah,
calling. Is those folks that never would see a PT or those folks that would end up just on the wrong trajectory. Because we have so
right.
many patients that might come in that might be well resourced, well connected, well supported.
Hmm.
They might have everything they need except the point in the right direction. So I think impacting people's trajectory through the healthcare system is also a key piece of what we do.
Yeah, absolutely agree. One of the therapists I worked with during my rotations, his kind of mantra was like, okay, if you come to outpatient PT, we're seeing you 2 out of the 200 and whatever hours are in a week, right? So,
Yes.
really, it's the way that you're going to get better is what you're able to do for yourself. And we're
Yes.
going to be able to kind of like act as bumper plates, right, in the bowling alley and guide you down the middle so that you don't get astray. And I think that that's really true in the emergency department because we're only seeing these people once, but if we can kind of plant the seed and give them the education, talk about triggers, talk about management, and then they can kind of be more effective on their own until they're able to follow up, or even if they don't follow up. And so, kind of like you're talking about, send them hopefully on the right trajectory so that they can manage this on their own more effectively and become pain free at some point.
I think that's so true. And I think that's kind of healthcare in general, right? Like people don't know what they need to
Right.
do. I mean, they just need somebody to kind of give them that information. And I don't know why we
Hmm.
expect people to know how to manage these considerations. So I have people that come into the ED and they're like, sure, it's an emergency. And those of us who are well versed and trained
Right.
in healthcare, we're like, God, why would they even come to the ED? I mean, I'm sure you've heard somebody say that. Why would they even come here for that? Well, they
Oh,
don't know
yeah.
what else to do.
Right. Yeah. They have no idea. And I think back to when I was in college, I went to the emergency department for everything. I was that person, because
Ah,
I didn't have a primary care physician set up. And something would happen and it felt like an emergency to me. And I thought,
yep.
oh my God, I got to get this checked out right now. And looking back, it's like, oh yeah, none of that was really appropriate to be managed by the emergency department. But I didn't know any better. And I think most of the people don't know any better.
Oh, I think that's amazing. So, talk me through the last couple of years. Like, how do you feel like you've changed and grown in these like I'm because you went from student, you're still relatively a new grad, like right into the
Yes.
fire.
Yeah. I think the biggest change is being able to trust in my examination and trust in my uh, feeling about a patient. Like I've had the benefit now of having multiple patients and presentations, so you kind of start to kind of recognize patterns. And so I think
Hmm.
that is the biggest thing is I've been able to arrive at things sooner than when I first started working in the emergency department. And also I think initially I was so intrigued by the challenge of finding out what's wrong with the patient that sometimes my exam would be somewhat to the detriment of the patient. Like I'd be so
Yes.
focused on figuring out what it was that then we're 65 minutes in, they're feeling worse because I've been
Worse.
putting them through all of these things. And it's for what, for my benefit mostly. And so I think recognizing that in myself and being able to be more focused on, I don't need to have the exact answer today, but I need to be able to provide this patient with something that's going to help them. I think that's been the biggest shift in how I've practiced since starting versus now.
Well, if it makes you feel any better, that is a lesson that I was still learning after 14 years of practice because I had a similar experience in the ED where I had a patient and with shoulder pain, and I was like trying to figure out exactly what was causing
Right.
it. Was it a labral tear? Was it this?
Hmm.
And I was torturing the patient.
Right.
Like, and I kept reassuring him and saying, no, like once we figure it out, like it's gonna be fine. And then I finally was like, I'm gonna just take a break. I'm gonna get you something for the
Hmm.
pain, and then I'm gonna come back. And I went and spoke to one of my colleagues, and I was like, hey, like I can't figure it out. And I feel like I'm making the patient worse. And
Yeah.
he just said to me, well, stop doing that.
Yeah.
Is it going to change how you're going to manage the patient today? So I think that's a lesson we all need to learn about the emergency department is that
Right.
ambiguity is okay as long as the
Hmm.
direction is clear. And in this case, what that patient needed was some symptom modulation, some protection, and a plan, not all of the answers. And so I went
Right.
back into the room and I said, hey, like, I've come to the conclusion that I may not be able to figure this out today. Your symptoms are too acute, they're too irritable, and I definitely haven't done a good job of helping reduce that. Are you okay with this plan? And then we'll get you set up with somebody else who can figure this out a little bit better for you when you're in less distress today. And he was like,
Right.
thank you. So
Yeah.
relieved. So I try to carry that patient with me. And the fact that you figured that out as a new grad is incredible. I
Oh,
think
thank you.
it takes a lot of humility to know, too, that we may not have the answer,
Right.
especially for patients who are so desperate for an answer. So one of
Right.
the things I try to carry with me is as little as possible to the patient, as much as possible for the patient. So that
Yeah.
helps me remember in those situations.
I like that. I like that verbiage. That's very helpful.
Yeah. I don't need to be doing all of this to them.
Right.
I need to be helping them. What
Yeah.
else? What else have you learned in these last couple of years?
I think at the beginning I was really buoyed by the catches I was making
Hmm.
in the emergency department, and then I've had some misses too.
Oh,
And
let's talk about that.
yeah, and I carry those with me and I would beat myself up about it.
Yeah,
But then zooming out, realizing it's like I'm not the only provider that they're interacting with. And
right.
so instead of beating myself up and saying like I didn't do a good job, which I could have done a better job and hopefully caught those things, changing it more to like, okay, well, now we understand what that presentation looks like and can we recognize it moving forward in other people, right?
Hmm.
Um, yeah, but the woman who pops into my mind is she had a fall and she was having like anterior groin pain, and they did a CT scan. It was negative. After they did an X-ray that was negative, they did a CT scan that was negative. And her presentation was kind of bizarre. Like I could range the hip fully, and she'd be like, "Not really. It doesn't quite hurt that much." Um, we got up into weight bearing, and she's like, "It's okay." And it mostly hurt when she would progress her leg. Um, and then she kind of vasovagaled on me, and I think at that point, I should have recognized, like, this is not a typical presentation if we're just assuming it's a soft tissue injury. Um, and so she eventually got sent home, followed up with outpatient orthopedic, which thank goodness, and ended up having a non-displaced, I believe it was a femoral neck fracture. Yeah, and had been walking around on it. And luckily, what they wanted to do was just go in, stabilize it, internal fixation. But they immediately had her be weight bearing as tolerated. So, she was only a few days out from where she would have been, thankfully. But yeah, it was one of those things that I was like, I missed that. I caused this patient more pain. I caused, like all these things that could have happened instead of recognizing like this is going to happen just to
Yes.
anyone who works in this field. Like we're not going to be
Yes.
100%. I wish we could. Um,
Yes.
and then, like I said, recognizing that pattern, that presentation, and being able to use that to make sure I don't, or hopefully don't miss it in the future.
I talked to one of the emergency physicians that I work with about that one day because I'm like, well, what if you're wrong?
Right.
And they're like, oh, well, we're wrong all the time. And I'm
Yeah,
like, but what if you like miss something? He's like, we miss stuff all the time. And I'm
right.
like, why is that okay? And he's like, well, because not everything follows the right pattern. Not everything's
Hmm.
obvious. Not everything declares itself. We make the best decisions we can. But my goal is never to miss the obvious stuff and to catch as much of the subtle stuff as I can, but give
Right.
myself grace. He's like, if we're making obvious mistakes and we're missing things that are like clear, like we should not be missing them, that's one thing. But he's like, being over vigilant is also harmful for your patients. So we
Yes.
have to balance that, and we know that that's part of the risk of this job. We know we can't do a comprehensive head to toe scan on everyone.
Hmm.
We will make mistakes. We just want to minimize that as best we can. So I try to think about that also. And if I'm really in doubt and I'm not sure, the best thing is that there's a whole team right there to collaborate
Right.
with.
Exactly. Yeah. And I think, um, talking to the physician, because she came back later after she was sent to us from outpatient ortho when they found out, and she was admitted through the ED for surgery. And so he and I talked about it, kind of did a debrief afterwards, and like, how did we miss this, and discussing it. And yeah, it is one of those things that is the benefit of working in the emergency department, is that you can turn to your left and talk to a nurse or a physician or whoever and discuss these things with it. And it isn't so much of a siloed situation as it can sometimes feel.
Yeah, and I think that kind of helps a little bit with that feeling of burnout too, when you know you're not alone and that
Yeah.
like the weight of the world is not like resting on your shoulders.
Yes. Absolutely.
What else has changed for you? Like I can tell just even talking to you how much more confident you are and like how much more certain you are about your path. And I want to know one thing that students I see struggle with is
Mhm.
that they don't see the progression. They don't
Yeah.
know what prognosis looks like. They don't understand that healthcare continuum. So it's very hard for them to set goals. It's hard for them to know how that um, illness or injury is going to progress, like what the normal looks like. So I'm wondering how you've kind of overcome that deficit since you don't have experience really in another setting.
Yeah, absolutely. That's been the thing I think I've struggled with the most. And I actually have picked up a day in outpatient to help with that, because
Love it.
I I did feel like, I'm telling these people these things and we're feeling better in session sometimes, but like, what do they look like the next day? What do they look like that night? And am I really like nailing these things, or am I missing it completely? And so, yeah, I've picked up a day in outpatient, and that's actually been really impactful in how I'm discussing things with um, my patients in the emergency department, and working with another outpatient therapist as a mentor. He's been really great in like, yeah, no, that's a typical prognosis, or like, oh no, that's taking longer than expected. And so that's been really helpful. I've also done some research to kind of see typically, tissue healing times, but also things that are going to affect that and maybe change the prognosis for these patients, different comorbidities that can affect that. And so I feel like that's allowed me to have that discussion with the patient more, and being able to safety net with them too, instead of giving them like a full on, it's like it can typically look like this, but A, B, and C may happen. Um, that's kind of what I've been doing to make myself feel better about that, because I do agree that that lack of feedback and following that patient on the continuum has been challenging,
Yeah.
working in this setting.
Yeah, I would totally agree. I think that it is hard when you don't know what to expect. But I would say in
Hmm.
other ways you have an advantage because you probably see more of the social determinants of health and how those impact our patients. So a lot of folks in outpatient, for example, or subacute rehab might not get that exposure because those patients that have really complex situations aren't making it that far. So
It's
I'm
true.
wondering if that helps you.
Yeah, I think it probably does. And I think I'm lucky in that the outpatient clinic that I'm working at has like a very holistic approach to these patients. And they have a registered dietitian on staff. And we have, like group meetings where we talk about how all these things kind of interact and can affect the patient and their healing and progression. And I do think, like, you're right, that working in the emergency department and seeing those things as well has influenced that.
I think too, it probably contributes to your success in outpatient when you know what people are going to the ED for. You can probably proactively educate your patients a little bit better.
Yes, definitely.
Okay, I love that. So, one of the things that you and I have a shared soapbox about is that practice in the ED is not just consulting for placement. So, talk a little bit about
Yes. Yeah. We've had a couple of newer physicians in the past, I would say year and a half, that have come on, and I've noticed that at the beginning, most of the consults will be for placement. And it's one of those things that it's like, well, if you haven't worked in the emergency department with a PT, you probably don't know what our scope is, what our talents are, and where we can be effective. And so that's a fun discussion. And so we kind of watch the tracking board and be like, oh, knee pain, and go talk to the doctor and be like, what's going on with this person's knee? Do you think they'd benefit from PT? Um, and having those discussions with them has been helpful, I think, to plant the seed in their mind of like, oh yeah, actually, let's get PT on board for these people. But yeah, that's the best part about being in the emergency department, is that we tackle, people who do have falls or injuries that allow them to be, or don't allow them to be able to go home safely, and we do help with placement. But we're also doing wound care, we're doing vestibular treatments, we're doing, someone who tore their ACL on the mountain 2 hours ago, and we're seeing them. And that's my favorite part of it, is that the scope is so broad in what
that.
we do, and it's not just, oh, you can't go home, let me help you get placed at a facility.
Yeah, I think that is an important part of what we do. It's
Big
an
time.
important part of preventative care, in my opinion, and in helping advance people's recovery. But it's also just the tip of the iceberg, right? So I would
Yes.
say other people might say, well, the rest of it's optional, but is it? If we're
Right.
really providing comprehensive care, if we're providing the standard of care, I would argue that physical therapists need to be present in the emergency department to help manage some of those other conditions because we truly are the experts in that. And we can
Yes.
help guide that decision-making process, especially with vestibular conditions. I know the new GRACE
Hmm.
3 guidelines about vestibular considerations in the emergency department really speak to the lack of training that emergency personnel have about even doing
Right.
a HIPS exam correctly, and that can lead to patient injury, misdiagnosis, overused resources, over needed
Right.
admissions, overuse of medications. And so that right there ought to be enough.
Yes, I agree. We've for whatever reason, I've noticed a lot more people being admitted to the hospital for vertigo after they've had scans that have been negative, but these people are just so debilitated that they can't go home safely. So then
Mhm.
people have been admitting them. And then what ends up happening is medically, they're stable. And so by the time they hit the floors, it now becomes a, hey, can you hurry up and see these people so that we can send them home and have someone else come to the bed? And
Right.
I agree. It's like this is a waste of our resources, a waste of the patient's time. In that it could have been managed, I think, successfully, not all the time, but successfully in the emergency department. And they hopefully could have gone home from there and had sooner follow up on the correct path that's really going to benefit them.
Well, and I think that speaks to the point that physical therapists in the emergency department can truly be gatekeepers to the entire health system. We can, not
Yes.
completely, obviously, nobody works independently in the ED, but
Right.
if you are keeping those patients out of a hospital bed, so many hospitals right now are boarding patients in the ED.
Hmm.
And if we have
Hmm.
people taking beds for something that could have been addressed as an outpatient,
Right.
or in at the bedside in the ED, that's like a profound misuse of resources because we know that
Absolutely.
outcomes for boarded patients are worse than patients who are admitted.
Right. Yeah, I absolutely agree. And um, it's hard, right? Like it's not going to be 100%, especially depending on the size of your emergency department. And there's typically only one physical therapist that's working in there. But yeah, I mean, even preventing like 10% of the people that are getting admitted when they shouldn't be is very impactful.
Huge. And if you connect that to dollars, it's ridiculous.
Yes.
What would you say? I mean, one of the things that I appreciate about you is your focus on education, and you don't limit that just to the patients. So talk to me about how you educate your patients, but also how you use those same education skills, those soft skills, to bring the team on board.
Yeah, I again, it's one of the things I really like. I like talking to people and giving them some autonomy in what's going on, especially with the patients. I think that's the thing that drew me to physical therapy in the first place, is that it's a relationship that you have with this person, and you're giving them the tools to manage it on their own so that they're not relying on medications or other providers to start to feel better. And I think, especially in the emergency department, that's huge because the point of an emergency department, right, is to screen for any big bad stuff that's going on. And then
Mhm.
after that, provide them some insight into how they should follow up. But there's a huge gap that's being missed, like, oh, if you have knee pain again and it's not fractured, okay, well, we think it's soft tissue injury, and then people get sent on their way. But how you manage, depending on which soft tissue is injured, is hugely important, and the education to the patient is important.
Yes.
Um, and working with the doctors here, like I said before, Lisa Tenbarge has done such an incredible job of really creating this like awesome reputation for PTs working in our emergency department. And so they really do trust us and value our feedback, which is great. And so I enjoy the aspect of sitting down and having discussions with the physicians afterwards. I've had them sometimes come up and say, like, what does your shoulder exam look like? Like, how can I do
Mm.
that better? And then they'll go do it and they'll come back and be like, I did it like this. Is that right? Should I do something different? And so I know that our people here are really receptive to that education.
Yeah.
But I do, yeah, I think it's really impactful, not only for them, but also for the patients. And that extends to even the EMTs and technicians that are working in there. Because again, depending on the size of the emergency department and also whether or not we're being consulted, sometimes the techs are the ones that are getting people up with crutches and are the ones that are putting on knee braces or slings or whatever. And choosing the right one and fitting it correctly is so important, and the education that they receive sometimes is lacking in that. And so I've really, our techs are great about being like, can you come with me while I put this on and just make sure I do it right?
Mhm.
Totally, let's do it, because it's just going to only provide better outcomes. And the techs are typically very interested in understanding why, right? Like,
Yes.
why are we choosing that brace versus this brace? Like, why does it matter where this strap is versus that strap is? And so I think, yeah, educating everyone involved, patients, doctors, and technicians, is something I enjoy and is really helpful.
I love that. I love that like sometimes our biggest interventions are is just education.
100%.
And there's no way to like overvalue that.
Right. Yeah, I agree. And it's um, the way that you say things and what you say really does matter. And I've
Yes.
found with patients before, if I'm not so specific and clear with them, or I don't have them do like a teach back, um, I've found those are the patients that end up coming back for the
Hmm.
same thing because they just truly didn't have an understanding because I didn't provide good enough education on whatever it was that I was trying to provide them. And it's like, wow, that could have just taken 5 more minutes on my part, more focus on my part, and these people wouldn't have ended up back in the emergency department for the same thing.
Totally agree. Love that. So if students are listening and they're like, I want to be Taylor when I grow up, what do you recommend that they do during school, clinicals, after school? How should they prepare for this type of path?
Oh, that's tough. I mean, I truly believe there's only so much you can do before you get into a rotation, and that's what's going to teach you the most. But I think like resources like you provide that gives a really detailed and concise understanding of what it is that physical therapists do in the emergency department is huge.
Hmm.
Listening to podcasts about different providers, because this is just my take, but and this is just my emergency department, but every ED operates differently, and the way they utilize physical therapists can be different. So like getting your hands on any material that's provided through the APTA, through you, podcasts, reaching out and even shadowing a day. Like Lisa allowed me to do that before I did my rotation. And it
Hmm.
gave me a much better understanding of what's expected and what does it look like and the chaos. Because on a surface level, it can sound like, wow, this is really cool. But then when you're sitting there and people are screaming and things are beeping in your
Yes.
ear and a nurse is talking to the doctor behind you, like that's not for everyone. And
No.
being effective and calm in your job, that's not for everyone, that environment. So being able to just even spend a few hours in there to truly understand what it feels like, I think would be beneficial.
I think that's great advice. The only things I would add to that are like students who say, "Well, I can't get a clinical in the ED." That's
Mm,
okay. What I would like to see from students is a variety of clinicals,
hmm.
not just outpatient orthopedics, not
Right.
just, outpatient neuro, not just acute care. Like if I'm going to hire a new grad to work in the emergency department, if you have clinical experience in home health,
Hmm.
outpatient,
Hmm.
subacute rehab, acute care, boom, because now you understand who needs to go to all those places and your discharge planning just leveled up. Your skill set,
Totally.
huge. Your toolkit that you have to draw on from all of those experiences, massive. Your ability to think at top of scope, incredible.
Yeah, totally agree. I think discharge planning is really hard when you don't have an understanding of what those facilities look like and
Yep,
how people need to operate in them. So I think you're absolutely right that working in those settings, having any experience there really does, like you said, level you up for sure.
perfect. So before I let you go, what's your like final top of scope takeaway for people?
Top of scope takeaway. I think that if you want to do it, you can do it. Like it sounds really scary and that there's a lot of barriers, but if you want to do it, it can be done. Like you can push for it. You can talk to the people in your emergency department or at your hospital about starting your own program. There's resources out there to help you. And it really does feel a lot scarier until you start working in it. And you're like, I have these tools, I have this education, I have this training to be able to do this. And so that's what I hope that people take away is that like PT and the ED sounds so niche and specific and like um, not for everyone, but I really think that if you're interested in it, then you would probably be successful, right? Like you're willing to put in the work to um, establish yourself in this setting and become a good provider and clinician in here. And I don't think that it's limited to, like you said, just people who have good outpatient skills and that's it.
Yeah, if you don't see the path, make the path.
Right.
I love that. Well, if you've enjoyed listening to Taylor, we are having a Top of Scope Summit October 5th and 6th, 2024. It is going to be a virtual 2-day conference, Top of Scope Summit, Practice Essentials for Practicing the Emergency Department. Taylor's going to be lecturing about the knee, what is essential to know about patients with knee injuries that come into the ED. So it'll be a value loaded conference. And if you want to learn more about EDPT, that's the place to be. Thank you so much for being on the show. You've been in the ED now and you're officially discharged.
Thank you.